Hello, my name is Bridget Baronic, and today I will be going over an evaluation of a randomized control called Mindfulness-Based Stress Reduction for Post-Traumatic Stress Disorder among veterans. In 2014, a randomized control trial was conducted to investigate the effects of mindfulness-based stress reduction therapy on veterans with post-traumatic stress disorder. The authors were particularly interested in this form of therapy for veterans that have poor adherence to other forms of PTSD treatment, which have higher rates of attrition. In the literature review, the authors note that some forms of cognitive therapy use trauma-focused material. This material may promote avoidance in the population and subsequently may contribute to dropout. Mindfulness is hypothesized to be better suited to this population as it promotes acceptance of thoughts, feelings, and experiences without avoidance. Mindfulness-based therapy teaches participants to live in the present moment. Thoughts and feelings are observed and acknowledged without judgment. The participants were randomized into two groups. The intervention group received 9 weeks of mindfulness-based stress reduction therapy, while the control received 9 weeks of present-centered therapy. Measurements were taken at baseline as well as weeks 3, 6, 9, and 17, otherwise referred to as the 2-month follow-up. Each therapy session was conducted by a trained professional at a large Veterans Affairs Center in Minnesota. While several different tests were conducted, the primary outcome of interest was the effect of mindfulness-based stress reduction therapy in comparison with the control group. Overall, mindfulness-based therapy showed a modest effect in reducing PTSD symptoms, and the mean difference between the groups was larger at the 2-month follow-up than at the 9-week termination of therapy. In the supplemental material, the evaluation methodology is described. Master's level independent evaluators were hired and trained by 2 of the study authors. Evaluators met weekly with the same 2 study authors. The training included measurement tools used in the study. Assessments done by evaluators were taped and reviewed by the authors, and feedback was provided until reliability between 2 assessments was achieved. Weekly sessions allowed time for evaluators to ask questions and receive feedback from study authors. Evaluation assessments began with the program protocol. The first summary assessment deals with objectivity, which examines bias, researcher bias, and confirms that the conclusions are drawn from the available evidence. In this trial, the study's methods and procedures were described in detail. Data is clearly displayed in tables and discussed in depth in the results section. A robust supplemental section is available that describes methods, control procedures, and treatment fidelity. The data presented in the study supports the author's conclusions. The authors use multiple measurement tools to provide data on PTSD symptoms, since self-report tools are subject to more bias than other forms of diagnostic tools. The authors selected the PTSD checklist as a measurement tool for the primary outcome. The tool is noted to have a high internal consistency as well as a high retest reliability. The authors selected other questionnaires to support the PTSD checklist and gain a more complete picture. Other questionnaires used include the Patient Health Questionnaire 9, Life Brief from the World Health Organization to assess quality of life, 5-facet mindfulness questionnaire to assess mindfulness skills, and expectancy and credibility questionnaires to understand patient satisfaction and expectations. Moreover, all the sessions were taped to investigate treatment fidelity. Tape sessions were reviewed and delivery was rated based on a rating tool. That said, questionnaires are still subject to bias, but overall, this study demonstrated a good level of objectivity. The next summary assessment deals with internal design validity, which assesses the credibility of the study. The study described its evaluation and inclusion criteria for participants and blinding in detail. For example, those unwilling to accept random assignment were excluded. It's clearly understood why participants were included, how the study protocol was executed. Concepts are well linked and logical. Emerging theories regarding mindfulness-based stress reduction were elucidated. Results from the study are well connected. The author describes the study results reservedly without over-embellishment. That said, there were several areas of note that may negatively impact internal design validity. First, the intervention group experienced a higher level of attrition than the control. The intervention group lost 22.4% of participants to follow-up compared with 6.9% in the control. This is a substantial difference between the two groups, particularly when considering the small and mostly homogeneous sample size from one VA center. The samples are also disproportionately men. The authors controlled for sex in the exploratory analysis, but not the primary statistical analysis. Budgetary constraints likely limited the trial to one VA center. Second, the nature of questionnaires, as noted previously, may introduce bias in participant responses. And finally, PTSD is a complex condition impacted by many factors. Thus, the effects of maturation over the course of the intervention and follow-up period are unknown. The next summary assessment deals with statistical conclusion validity, which is reasons why inferences of statistical association between two variables may be correct. The power for this study was set at 80%, expecting effect sizes between 0.5 and 0.9, with 0.5 being considered a medium effect. The alpha level was set at 0.05. The expected effect was not quite attained in the results. The effect size reported in the statistical analysis was around 0.4. While it's not extremely low, it should be noted that the effect size was indeed lower than anticipated and could increase the probability of a type 2 error. The p-values reported for the PTSD checklist at follow-up were less than 0.001, which was the primary outcome. So the results of this study do appear to be valid, but could be more robust with a larger sample size and should be interpreted with some caution. The patients recruited in the study were sent from the same VA medical center, which may result in the sample being more similar to one another than in the real world. Additionally, veterans seeking mental health care for PTSD may have different characteristics than those not actively seeking care. As previously stated, the sample consisted mostly of men, and hence the sample is representative of only a portion of the population. Lastly, PTSD symptoms are likely to be influenced by environmental factors outside the VA, such as family or work stresses, and the fidelity of treatment may be impacted by these factors. The next summary assessment deals with construct validity, which is reasons why inferences about the constructs used to define various parts of the study may be incorrect. While some of the metrics the author sought to measure may be traditionally difficult to capture, such as quality of life, the study was designed to improve construct validity. The authors used various clinically accepted measurement tools for ambiguous metrics. Other tools were included to support findings. For example, the PHQ-9 was used to rate depressive symptoms. It makes logical sense that if depressive symptoms decrease, quality of life measures would increase and vice versa. If these things happen in tandem, it provides more evidence for a causal association between the intervention and the outcome. The authors considered a time and interaction effect of the intervention. It's noted that the mindfulness-based intervention had greater time exposure at 26.5 hours compared with 13.5 hours for the present-centered therapy group, and thus could be a potentially greater effect. It's a potential confounder that should be explored in future studies. The blinded randomization helps to control some construct bias, such as participants assessing themselves differently than the comparison group. Both the interview group and the control received therapy for PTSD symptoms rather than having one designated treatment group and untreated control, which also creates stronger construct validity. The authors note that some effect from expectancies may occur, particularly therapist expectancies. Mindfulness-based treatment is a novel treatment strategy for veterans with PTSD. Few interventions have centered on it. Mindfulness is hoped to be an alternative therapy for those with PTSD that have been unable or unwilling to complete other forms of therapy. These ideas may have created excitement and thus potential expectancies in experimenters and therapists. The summary assessment dealing with external validity, or how well the findings can be generalized, had a few larger issues with it, particularly with the sample and budgetary constraints that limited it to where it could happen or where the intervention took place. The sample population was relatively homogeneous, and since the trial was unable to expand beyond one VA center, which would have provided more information on its external validity, that said, the findings of the study are consistent with existing theories. Through the supplement and published paper, the authors have described the trial in enough detail just to provide opportunities to replicate it. Given the information available, this study has some limitations on its external validity, but it could easily be replicated to test this further. The final summary assessment deals with utilization, or how useful the findings are through the literature and what they contribute, and also to stakeholders. The authors present clear findings in a detailed, coherent framework. The intent of the study was to examine mindfulness-based therapy as a potential alternative to other forms of therapy that suffer from high rates of attrition or are not well tolerated by patients. Given that PTSD is a chronic condition, it was postulated that increasing mindfulness skills would be useful to the population. In this particular study, mindfulness skills increased in the intervention group and self-reported symptoms were lower at the 2-month follow-up than in the control. This suggests that the skills acquired may help patients over a longer period of time. The authors note, however, that the longer follow-up times should be included to explore potential limitations to this. In general, this suggests new capacities of treatment that could be useful. The authors expressed some concerns with generalizability, as the sample was not representative of much of the population at large. In conclusion, the study was thoroughly designed. The authors used a variety of techniques to help control bias, such as independent evaluators providing trainings, using multiple standardized measuring tools, and taping sessions to review for continuity and quality. Bias is inherent in any study, and as such, there are some improvements that could be made. In my opinion, the primary potential for bias exists within the sample. The sample consisted of mostly men from one geographical location, and nearly all of them were in the same era. A more varied sample representative of the population at large would improve external validity and the utility of research. Thank you for listening to my presentation today.